Good evening and welcome to today's session on BIC streams. COVID-19 antibodies prevalence in Karnataka. What does the seroprevalence of 46.7% imply? This session will present the findings and implications of a statewide COVID-19 research report that was undertaken between mid-June and end August. The study has very interesting findings, and joining us are 3 out of the 4 authors of the report, Anuradha Acharya, Manoj Mohanan, and Anup Maini. And moderating this discussion is my colleague and the BIC podcast host, Pawan Srinath. Before I hand over to Pawan, a few quick instructions. Do follow us on our social media channels or sign up to our mailing list. We will be posting the bios of the panelists via the chat box, and do post your questions to the panelists via the Q&A box, both of which are at the bottom of your screen. With that, over to you, Pawan, and welcome everyone.
Thank you so much, Raghu, and thank you everyone for joining us. It's my pleasure to do this. I'm usually at the Bangalore International Center doing these recordings remotely, where we are putting together a podcast. It's a pleasure to do this live on COVID-19 and this important new study that's come out on our state of Karnataka. Now, since the pandemic has started, there's also been an explosion in information, and it's been like a daily or a weekly exercise in educating ourselves on virology, on statistics, on what seroprevalence means, what our serum antibodies are, and what they imply. And I think we've learned a lot in the last few months. So I'm hoping that there'll be a vibrant discussion today, which is why we thought that we'll just take the first 15 minutes or so to talk about the study. And I'm glad that we have 3 of the 4 authors here with us. After the 15 minutes, I'll have a few questions from my end for the panelists and the authors, and then we'll open it up to questions from all of you at the earliest moment possible. So without wasting more of your time, I want to hand things off to Manoj. Manoj, please walk us through the study, the main findings, and how you went about looking at Karnataka's COVID-19 seroprevalence.
Thank you, Pawan. It's a delight to be here to join you, and also thanks to Bangalore International Center for hosting us. Just a sense of background. So my co-authors Anu and Anup were both part of this effort that the IDFC Institute had put together, and a task force to help various governments with the initial phases of the COVID response. So in that early phase, Anup, as well as Anu and I, we were all trying to understand the testing technologies and what governments were doing with different types of tests, and what we can try and understand from different types of efforts that states and central government were trying to do with testing. So it was in the context of that we quickly realized that one of the key tools that the government needs is data, which sadly at the time was not available. Data for policy making to understand the extent and scope of the infections and how fast it was spreading and where, importantly, it was spreading. Because remember, going back to even in March, India had introduced one of the strongest lockdowns, the strictest lockdowns globally, before we even knew where the epidemic was. And so around May or so, Anup and I had been collaborating with the government of Bihar, and we were trying to test the migrants who were coming in using RT-PCR to understand current infections. And what we found was a surprisingly high percentage of migrants who had just come back, returning workers, I must say, not migrants, who had just come back from Bihar who were positive with infection. So this was already giving us the first sign that the infection in India was spreading quite dramatically, not just within areas, but across areas, going from urban to rural. So it was in the context of that we started a number of efforts to try and do large seroprevalence studies across the country. Anup and I were also part of an effort in Mumbai, which Anup will tell us about in a second. So the Karnataka study was part of that effort, and we started collecting data between June and mid-August of 2020. It was not easy, mainly because lockdown was in progress. Just doing basic stuff. It was hard to do your groceries, so you can imagine how hard it might have been to go out and collect data and come back. The main things that we found, if I had to summarize in a couple of sentences, one, the prevalence of COVID infections, past infections in rural areas was surprisingly high, probably almost as high as what we find in the urban areas. And our estimates for urban areas are fairly comparable to studies that have done this in other cities as well. So it's not like we are an outlier. The rural areas is actually the innovation. And the reason why we were able to do this is our partnership with our fourth co-author, who is not here on the call today, Kaushik Krishnan from the Center for Monitoring Indian Economy. Those of you who follow this might already know it, that CMIE, as part of its Consumer Pyramids household data set, conducts the world's largest household panel data surveys. They interview about 174,000 households 3 times a year for the past 6 years. So we had this really interesting sampling frame that we could borrow from CMIE and then sample households within that data set to be able to then track them. And that's what really helped us in several things. One is to be able to reach households that are carefully selected and sampled in rural areas, and also had better buy-in to be able to access these households and do the tests. So overall, what we learned is I should stop saying surprisingly, it's actually quite understandable, the high rates of seroprevalence in rural areas, but also that at that time, the infections in various parts of Karnataka, especially areas like the coastal parts, as well as districts like Mysore, were going through a fairly rapid increase in the rates of infection. And that's because we were able to test them both for antibodies as well as current infections. My colleague Anu Acharya would be able to tell you a lot more about the choice of different types of tests and our decisions about what to focus on and how we implemented them. So let me hand it off to Anu to take it from here.
Thanks, Manoj. So we had decided to do actually initially 3 tests, and then we focused down on antibodies using the ELISA method and also RT-PCR. I think a lot of you would be familiar with RT-PCR, but RT-PCR is basically looking at the virus, which is about 30,000 base pairs long, and we are trying to find certain parts of it in our nasal or throat swabs, right? So you're trying to find if there is an amplification of that of the virus, and you're trying to find that. So that will give us an understanding of what the current infections is. So whenever somebody wants to test if they actually are COVID positive, it means that the virus is still in their body. So we definitely wanted to look at the option of finding out how many are actually currently infected. But at the same time, I think the more important data was to also find out how many were already infected. And in order to do that, we are basically looking at the most common thing that happens after you're infected. That is, your body's immune system is actually sending out the warriors, the antibodies, and that's what we are measuring. So now you can measure this by many different ways. You can measure it by many different techniques. And the one that we chose was the one that was made by the Translational Health Sciences Institute. And this was looking at a specific part of the what we call as the receptor binding domain. And we tried to find that because it's one of the most sensitive tests, which basically means that you're trying to find something that will give you, when it says it's positive, it is, it's actually, they're actually true. So, right. So we're trying to find something, we are trying to find the most specific as well as the most sensitive test. And we found this test to be the most sensitive of all the other tests that were available. We also then decided to do an RT-PCR test. And the reason we chose the one that we did ultimately from bioMaru was also primarily for the same reasons. So we did both of them, and it was interesting because I think most of the surveys that we found before were either one or the other. And I think what was interesting in ours was that we could combine both. So it could sort of give us a sense of what happened in the past, but also where we are currently, so you can predict the future. Yeah.
Thank you so much, Anu. Manoj or Anu, would you like to add anything at this point, or shall I open up the set of questions that I have for all of you?
If I may, I just wanted to kind of, I think, Manoj, do you want to go ahead? No, okay. One thing I just want to clarify or just kind of characterize on Manoj's point, which is sometimes hard to think in percentages. Sometimes it's easier to think in absolute numbers. And to put in context what we're finding just in Karnataka state with what we found, what is reported nationally. And again, this is not inconsistent with any of the serological studies done, which generally tell us that there's a lot more cases. So right now, if you look, there are about 8.3 million confirmed cases India-wide. Those are just confirmed cases. Whereas what we're finding in this study with 46% seroprevalence is roughly 31 million, 31.5 million people just in Karnataka by say end of August may have been seropositive. And so that's a 3 times multiple just in the state of Karnataka alone, which gives us a sense of why just COVID testing alone won't give us a sense of how far the epidemic has progressed throughout India.
Thank you so much. And Anup, my first question is actually to you. I want to get a sense of how various seroprevalence studies have taken place across the country till date, because I think the Karnataka studies are the most recent, with perhaps the ones in Mumbai being one of the first. And I think you and Manoj were also involved with that. So give us a sense of what the different sero studies were trying to focus on. Here, one of your key things that you're trying to measure is a statewide number, right? You want to get an accurate picture with some range and with some bounds as to how many people might have been infected by COVID-19 before the study date. So could you walk us through the studies that have been done so far and what we've learned from them?
Yeah. So let me go ahead and just I'm sure the audience has heard of most of these studies. So obviously you've mentioned the Mumbai study, which occurs in July and then once again in August. Although it was the July results, I think, that were widely reported. Shortly after the Mumbai study, there was a Pune study that was reported. After that, there was a study in 4 districts of Andhra Pradesh that were reported, both in rural and urban areas, as it turns out. And then in the background, there was a study being done by ICMR. Was actually done over some time across many districts across India. And that occurs during this time, although reported a little bit later than the Mumbai study, if I remember. And then also there are 2 studies that were done in Delhi, just like a month or so or 6 weeks or so apart, repeat cross-sectional studies. So those are the kind of the span. I hope I haven't missed anything. Obviously, we've already mentioned the Karnataka studies, both the ones that we've done, but also the one that the state did. So there have been a number. And I believe that there's one that's ongoing. I know that there's one that's ongoing in Tamil Nadu as well. And there may be others that I've missed, but this gives you a sense of the number. And this is actually remarkable because I think in India, we have many more serosurveys than many other countries that are comparable. So it's actually a testament to how quickly we've been able to act. Now, there are 3 dimensions, I think, at least, that are critical for comparing or thinking about these studies. The first is when you do a survey and you want it to be representative of the population, you want to make sure that the sample you study is representative of the population that you want to talk about. And so what we want to do is compare these studies across how they selected their sample. And so I can talk a little bit about how that varies. A second dimension is the date during which you study. So we know that the pandemic rises and falls and rises. And so the prevalence that you're going to get, or the accumulated prevalence you're going to get, is going to depend on when you do the study. Earlier studies might find lower numbers than later studies. The third issue that's going to be important that Anu talked about just briefly is what tests you're going to look for. So are you going to look for actual presence of the virus, or are you going to look for antibodies, or are you going to look, for example, and this hasn't been done yet, although I think there's talk of it, look at T cell or cellular immunity. So those are the 3 dimensions that we care about. Now, the most important that I want to focus on, because I think there's nothing critical about early versus late date other than you want the latest data. What I want to focus on is the representation. So this is really hard. Having been involved in with Manoj in now 2 studies, and with Anu and Manoj in advising a number of states on how to do such sort of studies, we realized the challenge is finding that representative population. And so different people do it at different ways. So sometimes what individuals do, or what studies will do, is just say, I'm going to geographically disperse my population. I'm going to sample from a number of distant districts, 30 districts, 80 districts, whatever it happens to be. But then within the districts, you have to also be very careful about how you sample. So for example, are you sampling at hospitals? Well, that would be problematic. Because then you'll get an overestimate maybe because the people that go to the hospitals might be more likely to be infected. So it's not enough to just be geographically dispersed. You got to think within those geographies, how am I going to get the right population? And even when you do the opposite, let's suppose locally you're going to be very representative. You want to be a little bit careful about who you sample. So take Pune, for example. Pune did a good job of locally being very representative, but they were looking in, I believe, 5 areas of the city that had higher rates of COVID incidence. And so you're going to get a different estimate that's appropriate for high incidence areas. What we tried to do in Mumbai, and then what we tried to do in Karnataka, is to be take very seriously that representation. So in Mumbai, what we did is we went to slums and non-slums, but we selected a lot of different areas so that it was geographically dispersed and very representative from a physical space perspective. And then within there, we did what is called systematic sampling. So we went to every 4th house, let's say, and that way we were spread around the community. In Karnataka, we did something similar, except that we already had, because of the Center for Monitoring Indian Economy's representative frame, we already had a representative sample of actual households in Karnataka. So we had that frame set. And then within those, we then asked people what to do. So that's the approach that we took, and why it's important to be careful about that when you think about any kind of conclusions that you draw from it and how representative those are.
Thank you so much, Anup. And I want to maybe throw this to Manoj first, but please, all of you can chip in. This is perhaps the most important question to me. The number 46.7%, right? I mean, even if you take the confidence interval, that's between 43 and 50% of Karnataka. By about August, according to the study, had already been infected by COVID, like half the state's population. And we've seen, I mean, we know that the RT-PCR and the individual test counts are a heavy undercount, right? I mean, typically people talk about a 10 times multiplier, 20 times multiplier coming from sero surveys, but your study has found a 96x multiplier, right? So which is at one level alarming, at another level it feels like comfort, because okay, if that much of the infection is sort of gone through the population, then maybe we are doing better than we expected to. So can you help us make sense of that? Is this number very large?
Sure.
Did it surprise you? And
Sure.
how are you trying to interpret it?
Sure. I'll take a stab at it, and of course my colleagues will also probably want to jump in. So I want to start with something Anup just had earlier mentioned. Is like just don't look at only the numbers, but when we look at the absolute, not just percentages, but when we look at absolute numbers, these are staggeringly large numbers. And you are right, they are. Question is, how do you make sense of it? And again, I'll just hark back to what Anup just pointed out, is when you look at these numbers, you want to think about whether these numbers are likely to be biased or are they just imprecise. And the way to think about the bias, or whether we've got these numbers wrong, to put it in slightly less technical terms, is to think about how these samples were drawn. I'll give you a simple example. If I wanted to know the height of people in Karnataka, but if I had only gone out and sampled children or women or elderly or any of these groups, chances that I would get the correct number is very, very low, right? So the fact that we started with an existing frame of representative sets of households that CMI has been following, and it's not a small set, right? These are a very carefully curated set of households that give us a picture of what's happening in all of Karnataka. And within them, we are able to fairly clearly document whom we tested, whom we talked to, and who was able to participate. So it allows us to then correct for any differential participation, or the fact that, in the CMI sample, we have 41% young children versus 43% in the state. I'm just making numbers up at this point. But the idea that we have very clear information on who is being included in the study gives us a lot of confidence about whether these numbers are actually accurate or not. That's the bias question. In terms of sort of making sense of how these numbers compare, in some sense, it's not even, I'm not even quite convinced right now that if you had data in August from various parts of India with comparable studies that are able to do representative populations, my guess is we'll find estimates that are fairly comparable. The problem is right now we are comparing one study that has numbers from rural India versus a whole bunch of others that have numbers from urban India, and the assumption that rural India has not had infections. We don't know that, right? If we had data from rural Maharashtra and rural UP and rural Bihar, then we might have been able to compare and say, well, this makes or does not make sense. The only number instead we have, exactly as you said, is the number of officially reported RT-PCR cases. Right, in the nationally reported numbers, which was about 8 million a couple of weeks ago even. The challenge with that is the vast majority of cases in India are asymptomatic. You know, the early data coming from Maharashtra and Karnataka told us that about 95% of COVID cases in India were asymptomatic. Well, if it's asymptomatic, the only way I would get tested as an asymptomatic COVID patient is if my friend Anup, whom I was having drinks with last week, tested positive and he was symptomatic. And then through contact tracing, you found me, right? So the ability to get that 8 million number right depends on two factors. One is being able to find Anup first, which for reasons you just mentioned, we know that's not perfect. You know, Anup might not want to get tested because he's worried that Anu will not talk to him after he tests positive. They might not let him go eat wonderful meals at Anu's house and so on and so forth. Or he might be worried that the state might impose quarantine, or there might be social stigma, or he might think it's not important, or maybe he can't afford it, or maybe labs are not testing. There's a vast number of reasons why you first wouldn't find Anup in the first place. Conditional on finding Anup, you need to get information about whom he hung out with, aka me, and then be able to contact trace me, find me, convince me to test in time, because you know there's only a short period of time in which you can test me and find me positive. So all of these factors are working against us in getting that 8 million number correct. Instead, if we had done a random representative population and tested them for RT-PCR, you would be able to extrapolate what percentage of the population in the state or the country is currently infectious. And this is where we have good news. We at least have two data points, one from our own study where we find that some parts of the state, for example, states like parts of the coastal areas or districts like Mysore, had very high rates of current positive cases in August, up to 10%, say, for example. In fact, even some of the other data coming from other sources, the state surveys and stuff, show even higher rates across the state. Right? So if 10% of the population in a random sample or 12% by state estimates are currently positive, just give it 3 weeks and you will find that number doubling, tripling very quickly. Because remember, again, most of these folks are asymptomatic. If I'm asymptomatic, you invite me to your house for dinner, for a wedding, you have no idea I'm asymptomatic. I'm spreading it to everybody around. So the exponential growth is a major concern. So when you take these factors in and you think about the fact that this infection has been in India since March, we know that it was already spreading dramatically in May. By August, finding about 40%, 44% in rural areas is not that surprising. What is surprising is second part you mentioned about the lower numbers of deaths, lower rates of hospitalization than what you might have anticipated, given millions of people who are already infected. It could be a blessing in disguise. We're still trying to understand why that is the case. We are all very, very grateful and thankful for whatever reasons. We've not seen those kinds of hospitalizations and deaths in India. Anup, do you have more to add to that?
Yeah, I think I'd just like to add that, you know, we are not in Bangalore, but we are similarly testing in Telangana, for instance. And I think if you look at the kind of people who come to test are typically people who can, one, afford it, two, who are very aware. So I think there is a large majority of the people who just will not test, right? And so if there isn't testing going on in all the parts, we would never know, because even the people that we test, we find that majority of them did not need hospitalization. So there is a very large possibility that the people who are coming to test are not truly the actual numbers that we are seeing. And that's, I think everybody is sort of familiar with it. The second, of course, is that there is one part in our study, for instance, that we take consent. And maybe there is some room for error in that thing, because some people who refuse to give a consent, I think we can't get their samples. So there is, of course, that part that we have to also consider. But other than that, I think, taking a representation across the country, I think this was probably the closest that you could get to being able to say that, are we geographically diverse? Are we making sure that we have people of all ages? Are we having people of all genders and all of that? I think that part was very well covered. And so I think this was as close as possible that you can get. Of course, if we had a much larger number of samples, it would probably get easier to understand a little bit more as well.
Thank you so much, Anu and Manoj. Oh, one specific question about Bangalore, since I'm from here, and most of us who are who are listening in live might be from Bangalore. I found that in Bangalore urban, your sample was quite small, and therefore the estimate was also wide, right? I think 30 to 80%, if I'm not mistaken, and ultimately, I think you got antibody data from about 69 people or so from Bangalore. And given that Bangalore accounts for 20% of the state's population and perhaps accounts for 30-40% of the captured infections, at least, right? Those that have been tested officially. Do you think that that is a number that we can work on, given that there were other studies that you were all involved in which looked at a city specifically, and we're always concerned about population density when we're looking at an epidemic like this?
Absolutely. So I'll give you a quick response to that, and I'm sure Anup will have plenty to add on that as well. This is something that he's thought about a lot. So the first part is the study was designed not to tell us what the percentage of Bangalore's population is that's currently positive or previously infected. Right? That study design would have looked very different. And in fact, we are right now working on a follow-up study that will hopefully answer that exact same question. It goes back to this question of, what level of representativeness do we want? If we had got very precise numbers for Bangalore and let's say for Gulbarga, that still would not tell us what's happening in rest of Karnataka. And so the choice we had to make was try and get a Karnataka wide estimate, try and be able to then break it down by urban versus rural. We don't try to make inferences beyond that. I mean, everything that I tell you that things were happening in Mysore or coastal districts, that's just a trend that we are reporting, but those are not precise numbers that one would be able to hang our hats on, so to speak, from a study like this, right? So you're right. If we wanted to say something very deliberate about Bangalore, we probably need more sample sizes there. The other part is the reason why this happened, and I don't remember the exact numbers. You probably have the numbers in front of you. When we started this study, our estimates for Bangalore, we were going to do a lot more in Bangalore. Our target was about 500-600 households in Bangalore, which still is not huge. But the lockdowns that were imposed at that time in Bangalore were so strict that our teams had to leave overnight because hotels were closing down, the police was not letting people walk around and stuff. So these are just the ground realities of what it was. You're right. If we were trying to say something about here is an estimate for Bangalore, this is not the way to do it. That's just to be clear, that is not what this study is trying to say. Anup, do you want to add more to that?
Yeah, I mean, I think I want to stress that I know that you're in Bangalore, and Bangalore is an economically vital country, a vital city for India. But it's important to remember that India has a low rate of urbanization relative to other countries, especially in its own, even in its own income category. And as a result, it's important to focus not just on urban areas, but also on rural areas. And there weren't a lot of surveys that were doing that. And that's the reason we made a decision very early on. We were going to try to aim at getting both urban and rural included within this study. So that's just reaffirming or giving the logic behind our decision, the decision that Manoj talked about. But the second thing I want to point out just from Manoj's comment, which is critical, is early on in a lockdown, one of the key discussions we were having is, what are essential sectors and what are not essential sectors? And given our experience in difficulty in conducting this study, even in the context of lockdown, I think an important essential sector should be information gathering. So if we want to make good policy, we should make it possible for these sort of surveys to be done. Now, obviously, the government can do these sort of surveys, but we've seen over time that in a decentralized country such as ours, states and even collaborations with the private sector or academia can help provide this information. And so I think it would be important if this were to continue or if there were another pandemic to kind of have channels for these sorts of studies to actually occur so that we're getting up-to-date data. The third thing is actually just an additional comment or addition to a point that was made earlier. The gap between what you're finding in these serological surveys and what you're finding in confirmed cases. I believe Manoj talked about that. There are ways to address this going forward in this current epidemic, as well as thinking about what we should do in future epidemic. Instead of waiting, as Anu was saying, for people to show up at the lab or for people to show up at the hospital to get tested, even for RT-PCR, one of the things that we should have as an established channel is just doing population surveys, even with RT-PCR. And then having set ahead of time a strategy, the state having a strategy for finding a representative group, maybe even drawing on existing samples or pre-preparing samples that would go out and test. I think that and doing it repeatedly would have given us a more accurate estimate. Even though the number of tests we could do is very small, we could take the total number of positives and divide by the total number of tests done. And as long as it was on a representative population, we would have been able to track what the prevalence is over time and the accumulated prior infection, I think, more accurately. So this was a good learning experience as well.
Thank you so much. And, now I think it would be fair to say that both in rural Karnataka and in urban Karnataka, if I were to extrapolate data from your study, by today, at least 2/3 of the population or so might be seropositive. I mean, assuming that the antibodies have stayed in their blood, right? At least I think we can say that perhaps 2/3 of the population has gotten a COVID infection since March. Now, given if we take that as a reasonably confident statement to make, what does that imply for what we're doing to manage the rest of the pandemic, and what does it imply for the economy and society in general? Is the worst behind us, so can we breathe a sigh of relief, or is that premature?
So if I may, so I've been thinking about this both in two contexts. One is continued suppression, and second in the context of vaccination policy. So let's start out with suppression. One of the things that I think your question is hinting at is how close are we to something that people have talked about, which is herd immunity, where the reproductive rate of the infection begins to decline, which is a positive sign, but doesn't mean the infection's gone away. And I think the short answer to that is it's helpful for us to get some information or some conclusions about herd immunity, but not enough to know exactly when we're going to hit herd immunity. Remember, we did this estimate once. It's a population-wide estimate based upon repeated sampling within the state over the course of a 2-month period. So we want something, a little bit more accurate for a point in time in order to be able to infer anything about herd immunity. It's also the case that if you only have information on one point in time, you need to use some sort of epidemiology model to basically infer herd immunity. So it's one of those things where we want to continue looking to infer herd immunity. The one thing we can be sure is, and you're probably right, that we're a meaningful underestimate given that time has elapsed, and also we only look at antibodies and they may even decline over time, is that we may be underestimating, maybe it's 2/3, that doesn't seem completely unreasonable to me as an estimate of how many people have it, but that tells us the herd immunity threshold might be lower than that if we haven't hit a reproductive rate below 1 yet. So that's the first thing. And now the reason why that's important for suppression is because one of the things that you want to think about is you use suppression to stop the growth of the infection. That's one of the goals of suppression or lockdowns. And if we've already kind of hit that plateau, then you can actually relax suppression. If we haven't, we might want to continue doing that suppression. And obviously that'll vary depending on where we are. But right now, this tells us that there was dramatic growth despite our efforts at suppression, and that we need to kind of keep paying attention, maybe do this a little bit more to figure out if suppression needs to continue. Okay, so that's on suppression. But let me actually just add one more thing to that. There was a very interesting comment that somebody made to me recently, which is maybe we take solace, and it wasn't made to me, it was actually made on Twitter. Maybe we should take solace in the idea that 2/3 of the people already have, and I don't want to pick that 2/3 number and say it's authoritative, but it's your suggestion that 2/3 of the people already have it. It suggests that in fact the returns to suppression have gone down for 2/3 of the population, which is the other complication, which is suppression is usually not specific to individuals, for a whole population. So if you're already at 2/3, and even if you're growing, one thing you have to remember is on the one hand, you're growing, so that's a reason to do suppression, but 2/3 of the people are already maybe immune, and so the benefits of suppression to them are very low. And so as you approach higher immunity levels, you might actually want to reduce the amount of suppression that you do. Okay, that's suppression. I apologize this is taking such a long explanation, but the other part of this is vaccination. So when we finally get a vaccine, and we're getting good news, it seems every 2 weeks or so on the quality of vaccines and our ability to produce them. But when we get a vaccine, it's important for people to realize that distribution will take time, and that will mean that that we have to prioritize who's going to get the vaccine first, who's going to get it second, et cetera. And a critical thing that you learn from serological studies is that there's a portion of the population that's already infected and likely very immune. For those individuals, the return to a vaccine are much lower than for people who have not been previously infected. And so one of the things that we should endeavor to do is to target our vaccination first to those individuals who have not been exposed. Now, of course, that's very difficult. We've only done a representative sample, not the population. I don't know in everybody, even in this Zoom call, who's positive, who's seropositive, and who's not seropositive. So one of the things that we can do, though, is to look at different areas. And so areas that have lower exposure, but high growth, those are the areas with high return. And areas with high exposure and low growth are the areas with low return. And so that's how we can start using these data, both a combination of seropositivity and RT-PCR, to actually target the vaccine across different areas.
Can I just modify that last part, Anup, you said, just to clarify. So it's exactly this data, what we mean is it's this kind of data, because the data we have today will not help us inform this decision in 6 months. Things would have changed. I mean, you're already talking about 2/3, which is considerably higher than where we left it. And who knows what things might look like in April or May, whenever that vaccine might become available for distribution in reality. So the true challenge would be for the states across India to be able to do these kinds of studies, but not just exactly as we did it, because our objective was much more narrower. They probably will want to do studies such as this at a much more granular level so that they can say, look, here's exactly what's happening in Bangalore. This was the intuition you had, is can we infer from our data what's happening in Bangalore? And I said, no, but states will have to do that, and they can, right? They'll be able to do this within a 2-week period, just adopting strategies such as ours, be able to collect that data and then make the strategic decision that maybe they should be doing district 1, 2, and 3 later rather than doing districts 5, 6, and 7 that are right now at low levels of seroprevalence but high rates of infection. That's where the bang for the buck will come in.
I also want to add that I think people shouldn't infer that they can roam around without masks, because if you are in a community that hasn't been infected yet, I think even if the rest of the state of Karnataka has been in, there might be 50%. I think you should also be worried if your area or your sphere of influence hasn't had that infection yet, because it can still spread. That is one point that people should be aware of. The second is that there is also a possibility that the virus might mutate, and therefore we might see newer versions of COVID. So there are many other issues that one must also be worried about, and therefore I think people should continue to be a little bit more cautious about how they are conducting themselves in public life or when they are meeting other people.
Can I underscore Anu's point about this last bit? Is because of the way our family structures and community structures in India are organized, a lot of people who are elderly, who are usually at home, have not probably been infected as much as the younger population that has gone out, has been working, and so on and so forth. So if you think about, even let's say 2/3 are positive, who are the remaining 1/3 is a very important question. And if it turns out these 1/3 are overwhelmingly homebound older populations, then the chances, if tomorrow we just believe that the epidemic is over, herd immunity is here, and start going back to life as normal, as Anu cautioned us not to do, then that 1/3 is at risk of getting infected, and the chances of complications and mortality might be much higher there. So we should continue to wear masks, socially distance, physical distance, and wash hands. Like, I cannot overstate the importance of doing that, even at this point. Thank you.
And I apologize, but because it's such an important message, I'm going to say one more thing for why that should continue. A vaccine might be around the corner. So we're not talking about lockdowns that are endless. What we're talking about is taking personal precautions until a vaccine is here. So we just need to hold out for a little bit longer. And even simple procedures like masks make a huge difference, and avoiding unnecessary gatherings.
And if I might add to all of this, I think the antibody test coming positive is not the same as us having neutralizing immunity for the virus, and that is something only a vaccine can confer to us, right? Now, from data so far, reinfection rates in the short term for someone who is seropositive is low, but again, and declining antibody counts does not mean that your immunity has gone away. But again, I think we should be cautious about. There was this idea early in the course of the pandemic worldwide that you could have something like an immunity passport, right? So if you go for this COVID Kavach test, get your IgG positive for COVID-19, you're immune, so you can travel safely, and you are also less likely to be a carrier who will infect other people, even if you're asymptomatic. I think it's far too early to have that conversation yet, right? I mean, the science is not there yet. So, apart from your comment on that, I just want to get a quick sense of, okay, so a large scale lockdown at this level with this data does not seem to make too much sense because the spread is already in large places and the harm might be greater than the benefit. Two, in your study, you talk about the continued need for testing. Now, I'm a little concerned and curious about that because if the real infection rate is 100 times that of what is being detected, is there a point to more individual testing? How should we be viewing that? And that's probably my last big question before I throw it open to our audience.
Can I? I live in a family where I have 4 people above the age of 70, right? And I obviously, because I run a COVID lab and others, I've been not staying at home. But one of the things that one has to be very careful about is that your testing is not only for you; it is for the people that you interact with. So I think that's the most important, one of the most important messages that I want to tell people is that whenever they are asymptomatic, it's possible that they got infected, but it's not about what they did to themselves. It's also about what they did to 10 other people or 15 other people they interacted with, and therefore there is a need to test and make sure that those are isolated. For instance, I think when we look at offices when they're opening up, you're looking at large number of people coming into work in close, relatively closer contact with each other. And therefore, there is a need to, for instance, test over there and make sure that you isolate people who might be infected. But if you can restrict them for 2 weeks, I think you've stopped a much larger number of other people from getting infected. So I think maybe people think that because so many people have not had a problem, it doesn't mean that you won't be a statistic. There are lots of instances of cases where your own genetics might be such that maybe a normal 30-year-old will not have a problem, but so from a probability point you have a lower chance of getting it, but there is still a possibility that you might have a very adverse reaction to the virus. We've seen lots of instances of where very young people have died. So I think that's the thing that one has to be careful about, that yes, the good news is that large majority have not had a big problem. A large majority of our age group might not have had a problem, but there is still a possibility that one, you are passing it on to other vulnerable groups. And the second is that you can also be one of those statistical figures that you don't want to be.
Thank you. Anup, is there something you wanted to add?
Not specifically to that, but I just wanted to clarify one small biologic point. We do not know yet how long immunity. You are correct. We do not know how long immunity lasts when you've been previously exposed to COVID. Although the data coming out to me seem quite positive that as far as we know so far, like looking at the duration of the epidemic, it does seem to confer robust immunity, that the incidence of reinfection is relatively low. But of course, we haven't seen the long-term effects. But the critical thing we want to point out is it's not obvious that a vaccine, the immunity that you would get for vaccine would be different than, either greater or less than, the immunity that you would get from actual exposure. Both those elements require leveraging your own immune system and triggering it in order to stop the future infection. And so in that sense, they both have a very similar mechanism. And in general, we don't know which one is broader or narrower in terms of the immunity conferred. So this important thing for people to keep in mind.
Thank you. With that, let's open up to questions from our listeners and our audience today. Raghu, do you mind helping me out with this?
Yes, I'm here. Would you want to go first? Can you select the questions?
Yeah, I'm just going through them now. One of the questions by Katyayani Kuti is, what are the chances of a second wave of high seropositivity? Like, I think perhaps what she is implying is also that when we are looking at the RT-PCR tests, or at least that and the rapid antigen tests, we are seeing peaks and falls, right? Especially in our cities. I know that there's not enough data for that kind of a time series with us seroprevalence information. But how do you see then the pandemic going forward? Is it possible that a surge happens again in rural Karnataka or in Bangalore or elsewhere on the RT-PCR and the rapid test numbers? Can that happen in spite of these high seroprevalence numbers?
So one very quick way to think about it is the seroprevalence is a cumulative number, right? So you think of surges as about in terms of what's happening right now. It's unless the antibodies die down and then we are thinking about it coming back up again, it doesn't make sense to think of a surge in seroprevalence. In fact, if the antibodies don't die out completely over time, you will see that this number keeps going up and up, as exactly as you were trying to infer that it might be 2/3 now. By April, it could be even higher. So I wouldn't think of surges in terms of seroprevalence. The surges might be more in terms of current infections. To some extent, that's already happening, right? We've already seen this in happening in the month of September or so in various parts of India. Delhi is going through a surge. And part of the surge is also driven by exactly the kinds of concerns that we were talking about, that people start believing that I'm tired of waiting for this. Holiday festival season is up, marriages are around the corner, let's just forget it, let's go. That's what's leading to the cause, the spikes. The only way to deal with those spikes from a policy perspective, then, if you try to impose a restricted lockdowns, it will come down, and then if people don't change behavior, it will go right back up. So in some sense, we have to do exactly what we've been advocating for, is as long as people are going to wear masks, avoid unnecessary exposure, wash hands, use sanitizers, there shouldn't be too many spikes. Right? So it's not like a natural event that's happening. We are doing this to ourselves. And I think sometimes we have to take responsibility for that as well. That's at least my view on this. But Anu, do you have other views?
Yeah, I want to generally make a remark that we should be a little bit cautious in interpreting waves, and to expect the waves to occur. But what we're looking for is the underlying trend in the disease. So in generally, we think of two major causes of waves, that is to say, fluctuations in the prevalence of an infection. And one reason often is called seasonality. So for example, in India, you might say that during certain seasons, people are more likely to cluster together. And if there's an airborne infection, you're going to get spikes of it. So for example, maybe during monsoons, if people are inside more, you'll get greater incidence, and that could spark a surge. But the second one is just behavioral. And what I mean by this is that when we are trying to respond to the epidemic, we are making decisions, the government is making decisions on whether or not it should lock down. We're making decisions on how much to comply with the lockdown or to do additional things in response to that. And that behavioral component really affects how the infection spreads. And there are two features of this that make it so that naturally you're going to have these waves. One feature of this is that information comes with delay, which is to say, when infections rise, I don't see them, I as a citizen or I as a policymaker in government, don't see them immediately. In fact, what we see is there's infections, and then sometime later, some people get tested, and then sometime later we get the reports, and then sometime later the reports come up to us, the policymaker, or are published in the press, and we find out about it. That delay means that I'm always responding today to what the infection was before. So when it's low, I'm engaging in too much activity, which then causes the infection to go up. But by the time it goes up, then I respond and it comes down, but that'll cause a trigger, but it'll always be delayed. And that sort of delayed response is going to cause waves. Think about it as trying to adjust the temperature in a shower. The water temperature always takes some time to adjust. So you're always getting it wrong. It's sometimes too hot, too cold, etc. The second reason this is important is because there's a collective action problem, which is, when the government is thinking about this, and I will commend the government in the sense that it did act pretty quickly, but when the government is thinking about when to impose a lockdown, it is trying to figure out how much activity people are engaging in. And so they're waiting to see what the people are going to do to some extent. And to some extent, people are waiting to see what the government and other people are doing. And so we're always waiting to see what everybody else is doing to see if we have to act. And because of that, that also induces, even given when the information comes out, that induces a delay in action. And then again, that delay causes these kind of ups and downs in the curve. So what does that mean? That means that you're gonna see the waves on an underlying infection that might be increasing, just like your classic S-curve with epidemics. And so what we should be aware of is not that they're not waves, but that the waves are occurring because we're getting things at a delay. So the way to answer this is to try to say, for today, I want to project what is going to happen. I want to realize that the data I'm getting today is from the past, and then I want to project from that to what the actual data are today. So we're involved in separate efforts to try to do that sort of forecasting off of epidemiologic models, as are many other people. But those are the things that should guide policy. And if we can do that instead of just focusing on the immediate wave, I think we do a better job of accurately addressing the epidemic.
Thank you so much. And my next question I probably want to address to Anu. Ratnakumar is asking, should everyone get tested for antibodies? Is this advisable? I think there's a similar question from another person as well about what kind of antibody tests are available right now, and what kind of utility do they have to the individual? So if I want to go get a test done.
So I think most of the antibody tests are quite relatively inexpensive, and it doesn't harm, especially if you feel that you were exposed, or it's good to just know that you are, whether you were ever exposed and you have IgGs and all. Now there are many types of antibody tests. One that looks at the first response, that's the IgM, and then you look at IgG. That's the one that lasts for a long time, right? So that's the one typically that you would select for whether it's seroprevalence or whether it's just checking whether those antibodies have been there for a while. But then there is a third kind of this thing that you're looking at, the neutralizing antibodies. Now, there are not many of those available yet. There's one by GenScript, and there are a couple more that have come out, but there are not many of that. That will actually find out if a vaccine has been effective or not, right? So you want to see whether there is a neutralizing antibodies that have been formed, so that you can actually to check whether that, if you have been on a trial, whether that has been effective or not. So that will be the third. In terms of technology, you will find that there are the rapid antibody tests. So you basically look at an immunoassay, which is done on a little strip of paper, and you put a little drop of blood, a pinprick, and you put a little buffer, and it'll immediately tell you whether you are antibody positive or not within about 5 to 15 minutes. So those are the quickest, and you can do it, anyone can do that on their own. But one has to remember that not all of them are very, they're not as sensitive as some of the ones that you would do in a lab, for instance. So you have the ELISA tests, which is one of the techniques for doing it. And then there's the CLIA. The CLIA is supposed to be a little bit more better than the ELISA test. So I think if you go to any of the regular pathology chains, most of them would have any of these tests available. The rapid ones, I think only a few of them have been approved, and I wouldn't recommend too many of them to do, because some of them won't really give you the right results. So I think it's probably better to go with a regular blood-based ELISA or a CLIA test.
Thank you so much. We also have a question from Sunila Dikshit, and I'll throw this open to all of you. Sero surveys have been used to design elimination programs for polio, measles, and rubella in the past. So if you're looking at an end game scenario with COVID-19 post a vaccine, do you think sero surveys will be useful in determining that your population has achieved a critical amount of immunity against the virus, and therefore you can then say that your interventions can come to a close? Anyone?
So I think part of it we already talked about in the past is that I think there are two roles here. One is to think about the role of sero surveys in informing government strategies, we were talking about mainly in terms of where does the government invest its resources, focus its activities as it's rolling out the vaccination campaign, and that's a huge part. I think the question that you just described is an analog of that, is at what point does the government decide it's worth stopping at this point? I think seroprevalence studies can help for sure. But if you're already at that point, let's say we're fast forward now, 1 year from now, we are already starting to vaccinate a lot of people. One of the other things we'll start seeing at that point is that the number of cases will go down. And because then hopefully by then the number of cases becomes spotty enough that's where we would make that stopping decision. So take the case of polio, the stopping decision does not come simply because of antibodies. The stopping decision also comes when you know for the last 24 months or 12 months, there's not been a single case that you've been able to detect through very active surveillance methods. So that's something to keep in mind. Now, is that a practical solution for something like COVID, which is especially in a country like India, where 95% of the cases were asymptomatic? If you're going to look for active cases, you probably will not find it. My view on this is if we know that the vaccine hesitancy, which is something that we really worry about right now, a lot of countries, we know that in cases like the US, for example, if you roll out the vaccination strategy, about 30% of the people will not take it because of fears of the vaccine, lack of trust, so on and so forth. So in that setting, serosurveillance, but also doing active surveillance using RT-PCR methods like Anu described, can still be useful to test if this infection has actually gone away or is it still lurking in there and what the risks are. But unlike polio, we won't be able to wait for one positive case in the last year to decide whether it's done its job or not. Over.
Thank you, Manoj. I think several questions are relating to the sample size and the survey methodology. So if you could maybe just mention some of the numbers that you've sampled and tested and how. I think you mentioned how already with the CMI data that you had.
Yeah. So I'll give you just a rough overview, and to the readers, perhaps we can share the link, or if you just search on medRxiv for our paper, it should not be that hard to find. We can send the link around to registered participants as well. Overall, what we did was started with the CMI sampling frame, which is roughly about 9,700 households in the state of Karnataka, which has about 45,000 members in these households. And from there, we drew a sample of about 2,900 households. So that's really the number we want to keep in our mind, is we knocked on about 2,900 households, about 3,000 households, roughly speaking. And that's where we try to get consent for the surveys, the consent for the blood samples and stuff. And then we go from there. I noticed a comment in the question about, how many tests do you do per village? Again, if we were trying to estimate the incidence or the prevalence of this illness in that village, then that becomes a relevant question. That is not what we were trying to do. We were trying to estimate this at the level of the state and at most rural versus urban. So, if you want to look further down about how many samples were collected, blood samples and swab samples and stuff, there's a full flowchart in the paper. But again, I'd like to remind you that we are starting with about roughly 3,000 households as our target, knock on those doors, and then try to collect samples from there. Anup, did you have something to add?
Yeah, I just have two small things to add. One is what you really should care about is bias and variance. And bias is determined by whether or not we've sampled in a geographically representative fashion. So I'll tell you the pros and the cons. The pros are that we use the CMIE sample for the consumer pyramids, and we randomly select from that. So that, in that sense, what our starting points, our 2,900 are representative. The con is, obviously, as Anu pointed out earlier, all tests are subject to consent. You have to consent, otherwise I can't take your blood or I can't take your swab. And so if you think that people are aware of their prior seroprevalence and that on the basis of that, they're deciding whether to consent or not, then that would be a con. There would be a concern about bias. Now, we don't know which direction, whether or not prior exposure means that you're more likely to or less likely to consent, but that's the relevant consideration there. So that's what you care about in bias. Are we being representative even with consent? Then a second question, which is about variance, that is to say, how big are your confidence intervals? Remember, you pointed this out when you talked about our 46% number, goes from like 40 to 53. The size of that confidence interval is what's determined by sample size. So if you think our sample size is too small, you'll see it immediately in the confidence intervals that we report in the paper. And so that's your issue. Now, the way that you can adjust for that is to say, hey, look, even despite their small sample size, their lowest estimate is at least, say, 40% seroprevalence in the state of Karnataka. And that's the way that you would think about it. That would be the kind of the how bad we could be on the low end, and then how bad we could be on the high end. But that's, I think, again, transparent in the paper and captured by the confidence intervals.
Thank you so much, Anup, Manoj, and Anu for this fascinating conversation. And I must say that I really enjoyed reading the paper also because of how transparent you are with the survey methodology, who responded to what kind of samples. Often we see some of these reports coming out, but you have very little sense of what went into the study, and thank you for making this abundantly clear and easy for anyone to sort of verify or examine the study as well. My closing question or point to all of you: if there was just one thing you wanted people to walk away from, they forgot everything else about your study, but you wanted one message from your study that you wanted it to stay with people, what would that be for each of you? Maybe Anu, you can start us off.
Sure. That it's good news, but you still have to wear a mask.
All right. Manoj?
What she said.
Anup?
I'll say something different, but it's not going to be as important as what Anu said, or what Manoj said, which is we can do these surveys. They're not tremendously expensive, and we should continue doing these surveys if we want our policies to be the most informed and the most helpful.
Thank you.
Completely agree. Can I modify that one tiny bit? Completely agree. There's a tendency to make perfect the enemy of very good. This is very good. If you ask me if it's perfect, it's not. But let's not ignore some evidence that's really good simply because it's not perfect. So there's that as well.
Thank you so much. It was a pleasure hosting this discussion. And Raghu, over to you.
Thank you, Anuradha, Manoj, Anup, and Pawan. Data studies such as these that help evidence-based decision-making are welcome, and our thanks to the authors. One key takeaway, despite the high seroprevalence rate, is eternal vigilance and taking personal responsibility. So mask up, good hygiene practices, and social distancing, folks. Thank you, audiences, for joining us this evening.